Good morning, everyone. Hello. Let's try it again. Good morning, everyone. Yeah. All right. So let's see here. Got to get going on the. There we go. Um, so welcome to the 7th Symposium on Alagille Syndrome. And I am Cindy Luxhoy. I'm founder and executive director. And I want to welcome all of you. And bear with me while I go through these slides. I don't have my presenter view on my cameras or on my computer. So our theme is riding the waves, and you can't stop the waves. And that's a true statement has never been said about Alagille syndrome. I've absolutely learned that over the last 25 years and that Alagille syndrome is unpredictable. It's like a rogue wave, and you never know what's going to come, and when the waves do come, they just keep coming and coming and coming. But you can learn to surf, and anyone can learn to surf with the right tools and instruction. As people with ALGS and caregivers, parents and friends, that's what you do when you're challenged with this disease. If you have the knowledge and the tools, just as if you had a surfboard under your feet, you can learn to ride the waves. When my daughter Elena was diagnosed at 3 months of age, 25 years ago, I had a lot of questions. So many questions. How many of you are brand new to Alagille syndrome? Just a show of hands. Okay, we have a few. And probably some of your questions go like this. What are you talking about? Alagille? What? Was that my child you just diagnosed? What does this mean? Where did this come from? What planet am I on? And when you become an ALGS veteran and have been living with this disease for a long time, you also have questions, but they're just different. How many of you consider yourself a veteran? Okay, bigger show of hands. And that's great, and I bet you still have questions though. Like, is life ever going to be normal again? Does normal exist? What now? What in the world? Where did that come from? And what does the future look like? Well, I guess I consider myself an uber veteran. I've been to 7 symposiums now, and I've been an ALGS warrior for over 25 years. I lived and breathed this disease with my daughter Elena until she died last year. And in the symposium logo has a special significance because that's actually Elena's last heartbeat that's in the logo. And you know what? I'm still asking questions. I'm asking things like, why did my daughter die from this disease? What causes the gene mutation? When will there be a cure? Am I doing enough to advocate for families? And what can we do as a community to move research forward? When I started the Alagille Syndrome Alliance, all we had was snail mail. And no instant gratification there. I mean, it took forever to send things from one place to the other. And then came the internet, the web, the cloud, social media, a digital explosion. Today you can connect instantaneously with people around the world, and you can Google anything. There are no filters, and the load of information is huge. It can be overwhelming. But there's good news, because all of you are here you're in the right place to get your questions answered, right here, right now. You're in the right place to gather knowledge and tools that you need. And your ALGS family is all around you. Just look around the room. We're all in the boat together. And over the next 2 days, you're here and you'll learn to surf. Being in the right place makes all the difference. We're really thrilled that you're here, absolutely. And we think you've made an excellent choice, and we'll do everything in our power to arm you to be the best ALGS warrior ever. Over the next 2 days, there'll be a lot of information to absorb, guaranteed. It has the potential to make your head burst, to make your palms sweaty, to make you, bite your nails, and you might want to just go to your room and escape. But please don't. We're here to help. Our ALGS Board of Directors, and I think there are several of them in the room. I introduced them last night, but if you guys will raise your hands, we're all in the blue polo shirts, except Joe, who's wearing the symposium shirt back there. And we are here to help, so please don't hesitate to come up to us. And every one of us has quite an experience with Alagille syndrome, and we'd be happy to share ours as well as to hear yours. We also have our speakers and panelists in the room, and if you guys can, like MAB members, if you can raise your hands for us. So there's David and Ruben's back there. And then we also have some of our families, some of our veterans who will be on our panelists today. And they also have a lot of experience. If you've been wrestling with this disease for over 10 years, over 10 years, you know what it's like. And when I asked about, do you consider yourself a veteran? Well, there's quite a few of you in the room. And I'm sure that you'd be willing to share your experience with our newer family members. We're all here to help you cope, to advocate for your loved ones, and to thrive as ALGS warriors. We're here to keep you out of the whirlpool and in the calm space, at the center of the storm. Our goal is for you to leave here riding the waves with skill and ease. We want you to ask a lot of questions. We've set this up so that there'll be short presentations, panel discussions, and then we're looking to everybody to chip in with questions. We know that you have those questions, and jot them down as we go through the presentations or as the panel discussion is going on, and don't be afraid to ask. We're all here to help. And ask questions, demand answers, demand explanations. And until you're bursting with knowledge, and then ask more questions, because this is your opportunity, and it won't come again for another 2 years until we have the next symposium. So make every minute count while you're here. As my daughter Elena would say, her favorite phrase was live, laugh, love. And to that, I would add listen and learn. And above all, as she was, be fearless. So I'm going to ask you, are you ready to ride the waves? And the answer is? Yes. All right. And that's good, because that's what we're here to do. And I think that concludes my talk. I had a couple of reminders for everybody. So there are sign-up sheets. Once again, tonight we're going to do some chill-in chats. And there are sign-up sheets out at the registration table for those, like we did last night. And I encourage you to sign up for those. Let's see. Yes? So tonight, let me just pull out my schedule. Let's see what we got tonight. So tonight there's going to be a listening session again, which is those are with researchers that are just interested in hearing your experience with Alagille syndrome. They're trying to, they have research projects and they're trying to identify, what should they look for in Alagille syndrome as they do their research. And it just really helps them to talk to families and to understand what your experience has been, what ideas that you have about the disease, and just kind of how it's been for you. And so there are two of those. Albareo is doing one, and Shire is doing the other one. So and either of those would be great for you to attend. We also have the teen and emerging adults. They're going to get together again, and I think tonight, they're in here tonight. They were in a different room last night. There's also going to be an open Q&A out in the terrace garden for anyone who just kind of wants to talk to some of us veterans about how do you live with this disease. And we'd be happy to, kind of answer your questions out there. And then we're also going to do one, I know for myself, and we have, I believe, at least one other family that's here who have lost loved ones to Alagille syndrome. So we're just going to sit around and chat for a while. And I think that's it on that. We are in here all morning until lunch. We're doing back-to-back sessions on ALGS care. And then after lunch, we go into deep dive breakout sessions. And those are all on your program. And I guess the other question is, does anybody else have a question for me before we go into ALGS care? Right? Seeing none, I'm going to bring Kira up here and do a quickie introduction as she walks up here. So Kira Kennedy, she joined the ALGSA Board of Directors earlier this year. She's currently Chief Operating Officer for Amplix Pharmaceuticals, where she focused on novel treatments for life-threatening invasive fungal infections. Prior to this, she served as COO at Lumina Pharmaceuticals until the company was acquired by Shire. She was Vice President, Head of Cholestatic Liver Disease at Shire for a year after the acquisition. And as COO of Lumina, she played a critical role in the development of LUM-001 to treat Alagille syndrome and other liver diseases. She's a PhD scientist by training and graduated with a Master's of Business Administration in 2006. And I am going to find your presentation. Maybe. I might have to have some assistance. Let's see. Okay. Minimize that.
So while Cindy's pulling up the presentation, can I ask our panelists for the first session to come join me up on stage? So David Piccoli, Ruben, I'm not sure how you pronounce the Ruben's second name, Quiros, Meg Sath, and Laura James Beckham. Thank you. Rory. Take a seat. Okay, thank you, Cindy. And good morning, everybody. So I'm on the stage today with people who know a lot more about Alagille syndrome than I do. I spent several years of my life immersed in trying to figure out this disease and how to do clinical trials in this disease, and have remained committed to helping the world at large, which sounds very big, big ask, but helping the community of drug in the drug development field move therapeutics and new options and treatment forward. So I will view my role in this morning session as a success if you hear less from me and more from the panelists here and more from the people who are in the room who have questions. So just to introduce our panelists, I'm going to say a little bit about the panelists, and then I'm going to ask them actually to say a little bit about their interests in and experience with Alagille syndrome. So Dr. Ruben Quiros is a professor of pediatric surgery, chief of pediatric GI, hepatology, and nutrition, and the medical director for the Pediatric Liver Transplant Center at the Nebraska Medical Institute in Omaha. So Ruben, do you want to give any more background and some more of your experience with this condition?
Yes. When I was doing my fellowship in UCLA, I did some research in Alagille. It's a clinical outcome, basically. At that time, Dr. Piccoli and his group in Philadelphia discovered where the chromosome problem was and the jagged and all those things that we will know today. And I got fascinated by this syndrome initially in the scientific way. But slowly but surely, I got involved with the Alliance through Cindy and get to know now the patient side. And even though I don't do a lot of research today on it, I still take care of patients with Alagille syndrome. And I have been part of the medical advisory board for several years now, just to try to advocate for these children.
Thank you. Next on the stage, we have Dr. David Piccoli, and I'm sure for most people here, David needs no introduction. David was one of the first physicians that I spoke to about Alagille syndrome and met at that patient picnic up in Pennsylvania many years ago. But David is the chief of the Division of Pediatric Gastroenterology, Hepatology, and Nutrition at the Children's Hospital of Philadelphia. And really, I think that this group at CHOP have made many of the groundbreaking discoveries related to Alagille syndrome. David?
So I'm chief of GI and so on at CHOP, and I think, as you know, I've been at CHOP for more than 30 years, and my very first patient as a fellow at CHOP in July, just having come there, was an 18-year-old girl who thought she had both biliary atresia and congenital rubella, and I was intrigued by that, and maybe the rest is history. But at our institution, this has been one of the diseases that we've really focused on, and we've had at least 20 different faculty members who have participated in the research and the care and the genetics and the underpinnings, and we have really had the privilege to work with people for decades now, and all of these symposia and the regional symposia and the picnics I try to go to as many as possible, not because the food's so great, but because the people are great. So,
thank you, David. And it's also, I think, important to note that David and his group have essentially, they've written the book on Alagille syndrome. They have published over 60 papers, many chapters about the disease, the diagnosis and management of the condition. And David himself has attended all 7 of the Alagille conferences. So I think that with David, we have a huge supporter and advocate for this community. So I'd like to thank him for that. Next we have Dr. Meg Sath, who is an assistant professor of pediatrics in the Division of Pediatric Gastroenterology, Hepatology, and Nutrition at the University of Texas Southwestern and Children's Health. Meg?
So I am more of a general GI. I do some inpatient transplant service as well, and so I take care of kids with Alagilles in the clinic as well as on our transplant service.
Thank you. And finally, we have Laura James Beckham. And Laura is a family physician with OB and urgent care specialties. She's also the mother of Brianna, who's 22, and Gavin, who's 18, and the wife of Ed, all of whom are here at the symposium. Brianna was born in 1994 with Alagille syndrome, so I think she brings a unique perspective in terms of that caregiver, but also a parent. So, Laura?
Yeah, hi. We've been to 6 Alagille symposiums. We didn't make one of the first ones that was on the East Coast. That's what we missed. Life was a bit of a wave at the time. But I'm basically here because of Brianna and because I'm a family mom with a child with Alagille syndrome. And I guess I'm sitting on this panel because I have an MD at the end of my name, and I'm a parent, and somehow I'm trying to bridge these two worlds.
No, I think you bring the perspective of that veteran who's been riding
The
that
veteran that's been
wave
riding, yeah.
and living the world every day.
22 years.
I think that hopefully through this discussion you will find that there's a lot of knowledge and information that can help your own understanding and answer some of your questions. So let's get started. Oh, sorry, this one isn't moving. Got it. Sorry. So, Alagille Care Part 1. And it's Part 1 because there are 2 parts, and the second part is after the morning break. Throughout these sessions, we will address a number of topics, and the topics that we're going to address amongst the 4 sessions are, sorry, where are they? I apologize. We're going to talk about nutrition, we're going to talk about color, we're going to talk about, and in the afternoon session, we're going to talk about other topics that we will get to. So, Cindy already did the lightning poll, so I won't repeat that. I think that a lot of people in the room, from what I could see from the back of the room, are not necessarily newbies, but we definitely have a few newbies. And can I ask who attended the Alagille Basics 101 session yesterday? Okay, great, nearly everybody. That's excellent. I think that you'll see that the information here today will bridge on what you heard yesterday. So some of these slides may look a little familiar, and I think that that's okay because there are times when it's helpful to hear things a couple of different times and in a couple of different ways. So if you think you've seen it before, you probably have, and it's intentional. When someone you love is diagnosed with Alagille syndrome, you're bombarded with lots and lots of information. And I think the world of so much information at our fingertips on the web is both a joy and a curse. There's a lot of information, but maybe it's hard to interpret all of that information. So hopefully we can help with that here today. Cindy's very good with graphics and lots of pictures on these slides, so hopefully they'll be visually interesting as we go. And I'm sure that as a family dealing with a diagnosis, whether you're new to this diagnosis or whether it's something you've been living with for a long time, there's always too much going on. There's too many questions and there's too many things to address. And I know that in your packets, you should all have received a copy of this, which is the Alagille Care Manual. And this is really a step forward that the Alliance has been advocating for, to give every parent something that on their fingertips, which is something that they can look to as the first place to start with some of these questions. So we hope that you find this useful. So Alagille care. Alagille is a very complex and probably frustrating to deal with disease. It's a challenge that presents new challenges every day. It can be confusing and overwhelming and hard to know where to start. So this tool, the Alagille Care book, is meant to be a place for you to at least begin your thinking and answering of your questions. It's really designed with patients and caregivers in mind, and a way to help you think about child. Quickly move into the management. What should I do throughout my forward to go through the bile flows or doesn't flow in this condition. In many ways, as far as the body is concerned, bile is liquid gold. Although it smells awful, unlike real gold, it truly has no dollar value. If your child's liver can't circulate the bile, then it really does create a lot of problems that we just heard about. So, vitamins. We all know they're important. We all know that they do stuff. And I'm sure if you're in this room, you're acutely aware that if you can't maintain healthy levels, then problems really can persist. And these problems can range from maintaining healthy bones and skin, absorbing calcium, forming red blood cells, and a proper clotting of the blood. And the list goes on about what can go wrong if proper vitamin levels can't be maintained. When there aren't enough fat-soluble vitamins taken up in the digestive system, and really bile is a major component in this process, then this can be a sign of poor nutrition. So the fat's not absorbed correctly, and this can lead to poor nutrition and growth. And a person's poop, getting the theme of the morning, poop, it might look strange. And anybody want to comment on what to look out for in terms of poop? Ruben, you set yourself up to answer, at least have a first pass.
Okay. Then, since I am become a poo-poo doctor here, okay. I think the important things in the stools are going to be color is one thing that you look for. The color of the stools mainly come from the bile and give you a sense of the transit through the small bowel and the colon. Then if it's green, the green is really going past fast, and then the darker stool, yellow is kind of halfway, then brown takes a little while to get out because the bacteria start acting on the bile and changing the color, and then all the way to a little bit darker brown, darker stool. Then one thing is you don't have enough bile in your stools. It may look like light yellow or not because there is not a lot of bile in. Then the other one I will say is important because we're talking about the nutritional aspects of what to look for, is when there is fat malabsorption, the stool smell really, really deep down. It's a very particular smell. You know, if you change the diaper in your kid, everybody in the house is going to know that there's going on some diaper changing, because the odor of that stool is really different and peculiar, very, very false smell, what we call false smell. The other thing is you have a kid that goes to the toilet already, it's a stool that's going to float in the water of the toilet, in the toilet of water of the toilet. Then it's not going deep down. I'm getting deep into the poopology. But if it doesn't get down into, doesn't submerge, but floats, that's a sign that there is more fat into the stool. And that's a sign of fat malabsorption.
So I see Laura nodding her head furiously over at the end. And anything you wanted to add from the parent perspective, things that you observed and acted on?
Well, initially the whole white poop, because there is no bile in a newborn that can't actually pass the meconium. There's no meconium. So our daughter had no bile passage happening from the beginning. And we had really strange poop. Our newborn, it was my firstborn, and I remember thinking, this is not right, and I don't want to see this. Actually, there was a lot of denial for me. I did not want to see this. I knew what I was seeing, and I wasn't going to see this in my child. And then you can overdo poop. You could be running to the doctor with too much poop. So sometimes you just need to go, yeah, whatever, people's poop changes in different colors. But the floating poop is important, and the funny smell. And it does give you some idea about what's happening with some of the medicines, whether or not they're helping with absorption or not.
So can I ask a doctor a question of the physicians on the panel? Is it helpful for a parent to bring you samples, or are descriptions enough?
So I think nowadays, actually, a lot of people take pictures.
Mm-hmm.
Usually we're, as you can tell from Dr. Kiros's discussion, we're pretty familiar with poop. So if you describe it to us, we can probably get the gist of it. But pictures are fine. They're probably better than samples unless we need to test particularly for something.
Okay, well, I think that's helpful, so knowing exactly what to do with when you have an observation. So take a picture and describe it to your physician. Okay, thank you. So we're going to leave poop for a minute, and I'm sure we'll come back to it, but sorry, we're a little behind on, okay. So reflux, or spitting up, vomiting up food, may also be a problem that you face, and getting children to take their medicine, I think, is always a challenge. And if they're on numerous medications, I think that challenge becomes amplified over time. More often than not, most children with Alagille syndrome are on many medications, and we'll talk about the challenges associated with this and eating and digestion in the question session. So if you can hold that for a moment. You know what, I'm actually going to take a break here and have some discussion about eating and digestion, vitamins. So, should children with Alagille be on a special diet? And if so, what kind? Is there any generalizations about that, or is there any guidance that you would give to parents? David, I'm going to get you to answer a question.
I'm worn out from last time.
So most of the time, because there's fat malabsorption, kids with Alagilles need more calories than your average kid the same age. We do encourage high-fat diets, but the conversation of high fat has changed a lot. So we're not asking you to take your child to McDonald's for every single meal, but we're trying to encourage healthy high fat foods. So avocados, nuts, good oils. So you want to make sure that you're still trying to keep a nice nutritionally balanced meal, but you're still adding good high fats, and probably you're going to add a little extra to everything that they're eating. So if you're giving them, macaroni and cheese, you might add a little extra olive oil, or even in the baby food, if you've ever looked at baby food, it actually doesn't have a lot of calories at all. So this is why a lot of times we tell you to stick with high-calorie fortified formulas first, and then the baby food is part of learning how to eat, but we'll ask you to either add rice cereal or a little bit of oil to the baby food as well. You can also mash up avocados, which are good for babies, and good high-fat foods. In terms of...
Not yet. Is there anything to stay away from?
Not really. Occasionally it's fine to give them McDonald's or milkshakes and things like that are high calorie, but we do want to encourage most of the diet to be focused on more healthy fats. You also need carbohydrate and protein, so just because we focus on fat doesn't mean that you don't need those things for children to grow. And even though they have liver disease, one important thing is that they get the appropriate amount of protein. It's only in very at the end stage of liver disease that sometimes we limit protein. Even that we're very careful about, because your body and your muscles still need protein to work well. So even if your child has liver disease, you shouldn't try to decrease the amount of protein. I wouldn't give them a huge amount above what's recommended for their age. And you can always talk to a dietitian and your physician about what's appropriate in terms of protein. But a lot of times people think that since the liver processes protein, if you give too much, then that's not going to be good for them.
Okay, thanks. Ruben?
I think the one most important thing about intake for particularly infants is that you get enough calories into them so that they grow. So their ability to absorb carbohydrates is pretty close to normal. Absorbing proteins is normal. Fats are complicated because there are certain kind of fats that they will not be able to absorb very well, certain kinds of fats that they can absorb well, and for a long time the formulas that we used were very high in these fats, but it didn't probably work nearly as well as we thought. So the single most important thing is not how many calories they drink or how many calories that the dietitian calculates for you, but are they growing at a reasonable rate? And so we've moved much more toward tube feeding and G-tubes for the children who have significant liver disease. And we would like to see a show of hands of how many people had either an NG tube or a G-tube put in to support the calories. Yeah, and we feel that the single most important thing is that, and you have to take into account the fact that fats may be malabsorbed at a rate of 30 or 40% of the calories. So I think Joe was saying that when he was in the Boy Scouts, he ate more than any other scout, right, Joe? I see you back there. They were impressed. But he was transiting a lot of that food outward. So I think it's very different child to child, and it's different if you're trying to do it orally versus if you're delivering it by tube, and I'm sure we'll talk about it. But the tube is also a way to deliver medications that have this crazy schedule that goes on for 14 or 16 hours of the day, and this one can't mix with this one, and you know, some of them are really among the worst tasting medicines that have ever been devised. So I think many people would say when they finally went to a tube, life got better, now we enjoy the food, and we're not psychotic about getting the calories in because we can do that at night or some other time. Anyone else want to comment on that?
Actually, on that, if you have a question, if you have a burning question that you want to ask that's relevant to the topic, please feel free to ask it in real time. Does anybody have a question on anything that's been discussed so far this morning? Okay, we have.
So what is your opinion on adding MCT oil, medium chain triglyceride?
Yeah. So it's a good oil. It's the fat that is absorbed by a slightly different pathway, and so it can help to get calories in. I would say, and we could do polls in here for the parents who have children who are 15 to 20 years old. We used to give 50% of all the fat in the diet was MCT, and we used to rely on these kinds of formulas, and there would be a lot of slurpy stools, and it didn't work quite as well, but it is a fat that gets in, so it's a good strategy. It just can't be used like massively. And so some formulas have, as part of their formula, MCT built into the formula, and you can also buy, you know, extra virgin olive oils here, and then go to the drugstore and you can buy a quart of MCT for a lot more money, even than the extra virgin. It's a good strategy. It can't be relied on solely, and there's still a fair amount of malabsorption with it.
Any other questions?
I'm just wondering why it's so hard, like for my son to gain weight. I mean, he does eat a lot, and I just wonder where the food goes. You know, I mean, it just seems really, really hard for him to gain weight.
Yeah. So, I mean, the answer to that, and you've heard parts of it, of all the different things that the liver puts out, almost everything that it puts out is garbage that you need to get rid of, except for the bile salts. And so the bile salts are like your detergent, your laundry soap. And if you take a fat globule, and if you don't have a detergent, it stays in the water in your gut as a globule, and it can't be digested. So we evolved with the idea that we were going to get some fat in our diet, and these things are, you know, I think as Cindy said on the slide, you know, liquid gold for digestion. In Alagille syndrome, if the ducts aren't adequate to let that bile salt come out, then you can't break down those big globules into little globules, and then the enzymes that break apart fats can't ever touch all those calories. Then they just come out. So in a baby's formula, 50% of the calories are fat. And if you're barely absorbing that fat, you can't possibly grow. The body knows that those bile salts are so important that it puts them out up top, and then it evolved an entire mechanism to call them back into the body down below. And that's the That's a lot about the strategy that you'll hear about with anti-itching, because for most people, you need to bring these back into the body so that you can recycle them again and again and again to digest fat. And part of the problem in Alagille syndrome is you can barely push them out up top, so you don't get good absorption, but down at the bottom still really pretty good, and it brings them all back. But then the body has so many extra bile salts in it that that's what causes itching and some of the other symptoms. But the one issue is that they don't absorb a major amount of the calories. But the other issue, and I think Laura brought it up last night, around things like taste and appetite, is they don't or can't eat enough calories to grow. So even if they eat a lot, the answer is they have to eat more. And so a lot of times you just can't push it more at the top. And many kids, I mean, I'd be curious, there's so many children with Alagille syndrome who like really spicy or really weird foods. I mean, compared to like kids' tastes who usually eat like fries and, you know, sort of things. But is there anybody whose like child puts hot sauce on their food, or really like tons of, see all the hands, you know? So there, and Laura mentioned this last night, and I didn't say anything, but one of the toxins that has to come out of the body from the liver is copper. And when copper and zinc kind of balance in opposite directions, and so many patients with Alagille are zinc deficient. I don't know how many people in here are on zinc as a supplement, but one of the signs of zinc deficiency is poor taste, poor appetite. So, you know, there are all these different things in play, and what you really at the end of the day need to do is, if you can't make it with all kinds of good food and good encouragement, is really put in a tube and get them to grow, because so many of the other complications of Alagille syndrome are downstream from poor nutrition and poor vitamins.
I just want to make a comment. I know we are focusing on nutrition, but I think also you have to look into each patient individually, because there are some other issues that could lead to failure to thrive, like heart disease, kidney disease, and there are some other organs that affect that. We will talk about that later. The other thing I want to point out as well is that really look at the child and how it's growing, because something I have found in my career, sometimes kids are labeled like failing to thrive, but it's truly a lack of understanding that there is a different pattern of growth in the patient, that they follow their own curve. As Dr. Piccoli and his group show from some studies and stuff we have seen throughout the time, is that the kids, everybody gets all so anxious about the way the kid's growing, but he's following his own pattern. It's probably, you know, you have to probably look at a growth chart for an Alagille syndrome kid sometimes. Some of them may grow well, but the spectrum of the disease is so wide that I think each one has to be looked at differently to all the components and how things are moving in time. I think more importantly is to see the child gaining weight, following the curve, even though if it's below, and follow the curve, even if it's in length also below, but at least having his own pattern. I think is more important than focusing on where the actual plot of that kid is.
So Laura, as having been there, done that, any comments on special diets or differences in growth for your child compared to, you know, what you were hearing from your doctors or your other concerns?
No, I think it's all been covered, yeah.
Okay. Well, then let's, if there are no more questions from the audience, oh, we have another one.
My question specifically on oils, and I know we touched on MCT oil, but as far as incorporating additional oils into your child's diet, do you recommend, like in terms of quality, like cold press, like, you know, extra virgin olive oil, avocado oils? If you were to name 2 or 3 different oils, what would that be?
I usually recommend olive oil. Some people have had success with like coconut oils, which are a little higher fat. And then obviously MCT oil. I don't know if there's any other.
Yeah, I think, in the evolution of this, there was a period of time where we thought, because cholesterol is such a problem, we tried to avoid everything that had cholesterol in it. And so healthy oils are just healthier. There's never really been a study in Alagille that says that this one is healthier than this one. All of those longer chain fats are going to be malabsorbed to some degree, and the more jaundiced your child is on average, the more of those are going to be malabsorbed. But the one thing to know, and as Dr. Quiroz said, the stool doesn't look very lovely, but when you malabsorb tremendous quantities of fat calories, you usually don't suffer much. When you malabsorb carbohydrate calories, that's the gas, bloating, explosion, pain. So if you overload a little bit oil, and this is what most people recommend, and you have a little bit more come out, and you have oil droplets, around the stool, and I mean, you just know that that's a sign that there's a lot of leakage. It's not really harmful in a way. So I think whichever oil you feel is, healthy, and there's a whole spectrum of the healthy oils. I think what we know is bad, and for a long time, we were doing things like, and we were doing it in the American diet as well, like we weren't using butter, so we were using margarine. It's quite clear that things like the trans fats were really, really bad and probably worse for Alagille even than they were for the rest of us. But it's not as much of an issue now since they've gotten a bad name and they're gone, and high fructose corn syrup is following right behind them.
Thank you. So let's talk for a minute about vitamins. So we heard a little about how important it is to have adequate levels of A, D, E, and K in Alagille. And here's a two-part question. Should every child be on vitamin supplementation? And if so, what kind? And are there any vitamins or vitamin levels that can be toxic?
So there are some vitamins out there that have A, D, E, and K in water-soluble form. There's different versions of them, but most common one is called Aquadeck or ADEC. Sometimes the problem is that they're hard to get through your insurance and a little bit expensive. Also, in the combination vitamin, you don't always get appropriate amounts of vitamin A, D, and K that your specific patient needs or your child needs. So a lot of times parents get frustrated because they're paying for the ADEC or finding a way to get it. Plus, then we tell them, you need more A, you need more D, you need more E, and you need more K, which are also more expensive and usually not covered. So sometimes it's actually better to just supplement individual vitamins based on levels. You get more bang for your buck, and then you're kind of also targeting exactly what your patient or child is deficient in. And then we will follow vitamin levels to try to make sure that we're achieving the appropriate levels. The other thing is that usually we try to get you to give the vitamins first thing in the morning if you can, because that's when hopefully you have the most bile excretion, natural bile excretion out. So we try to get you to give them in the morning. Sometimes it's hard because some preparations of vitamins can cause nausea, or kids are uncomfortable taking them in the morning because they get a bellyache or something like that. And then I'll let someone else answer the rest.
Yeah, so I first point, I agree totally that when you have the combination preps, they may work for one disease and not for another disease, and the disease they don't work as well for is Alagille syndrome. And it wasn't what they were really originally developed for. So the one question that Dr. Kennedy asked, vitamin A is definitely a toxin, and it's a liver toxin. So can you get too high levels of something? There's so many things in life that a little is good and a lot is really bad, and vitamin A is one of those. So, and we find in our patients that the number of patients, it should be monitored from time to time, but the number of patients who are vitamin A deficient is surprisingly low. So the D, E, and K, different patients have different requirements for that. And so we do mostly dose individually. And then you have different strategies. So you need to be on the right kind of E. And maddeningly, some of those products go off the market, or you can't get them for 6 months, or, you know. Vitamin D, there are sort of 3 different kind of groups of vitamin Ds. There are 2 groups that are sort of the same, ergocalciferol and cholecalciferol. And then there's a very activated vitamin D that bypasses some of the regulation. Any show of hands, and I know there's at least one guy out in the terrace who has rickets, and he went on calcitriol or rocaltrol. So that's the next level of vitamin D that is already activated and bypasses some regulation. It needs to be watched carefully. And when you go to vitamin K, and a number of prescription plans have now dropped covering vitamin K, and vitamin K it's one of the many medicines that has become astronomically, I would say, unconscionably expensive. And so how many people in the room, vitamin K orally is not enough and they go in and get shots? Yep. So there are these different strategies, but the bottom line is you have to get every one of these vitamins into the right range. And so sometimes for the vitamin E's, you are talking about doses where your insurance company will look and say, you know, does your doctor, like, did they miss a decimal point? Because you're giving 100 times more than the recommended dose. I would say the other thing that Meg said, almost never should you accept from your insurance coverage that they will not cover these vitamins. These are not nutritional supplements in these doses. These are pharmacologic therapy, and your doctor should be willing and able to write a letter that says, without this vitamin E, there will be permanent nerve and brain damage, and you will pay for this downstream if you don't pay for it now. And also there are many times where, you know, in our state, you can get state Medicaid secondary to pay for absolutely everything, you know. And so because otherwise these can be easily $500 a month out of pocket. And so sometimes, you know, you make that compromise. I can't afford this, so I'm not going to do it. Some of these things are really, really, they're all, not some of them, they're all really, really important. And of the things you can do to make your child better, make sure they're monitoring the vitamins and get them up into a reasonable range. That is something that's, you know, in your control. There are a lot of other things we'll talk about that are not really in control. Yes.
Just out of curiosity, how often would you recommend a child with Alagilles to have their vitamin levels tested to monitor?
So, you know, one of the things that Cindy asked was a cookbook of exactly how to do all of this. You know, and I think, you know, we all go crazy when we watch TV shows and they're like, throw some of this, throw some of this, throw some of this, see how it tastes and it'll be great. The recipe for monitoring really varies. So in the first 2 years of life, the brain is growing. You know, these vitamins are critical for a whole bunch of different functions, and the baby has very little blood, right? They're small. So we monitor as frequently as we can. You know, in our center, we almost never monitor vitamin A. It takes a fair amount of blood, and it doesn't usually tell us anything. We're very concerned about vitamin E. In a child who has Alagille syndrome, but they're 90% cardiac and only 10% liver, you can have them on low levels of vitamins and they'll be fine. Probably every 6 months is fine. The older kids, I think we don't ever, I'm sure we break our rules sometimes, monitor less than every 6 months. But in the early age, you want to monitor those things as frequently as you can. And, things like the liver enzymes and so on. And in most pediatric centers, they only take like a nothing amount of blood now. But those things don't really matter much. If your ALT is 150 or 250, makes no difference. Tells you nothing important forever. And so we probably emphasize those things less, but we certainly don't want to find out that the PT is 17 seconds or the INR is 1.7 when you can do something about that. So it's very individualized, but I think a lot of times when we see people for second opinions, they're not monitoring the right things frequently enough.
David, just in case people don't understand the relationship between INR and vitamin K, do you want to just extrapolate?
Yeah, so, and we heard last night from Laura, a story of significant bleeding. And there's a French paper from a number of years ago now where they looked at hundreds of their Alagille patients. And they saw a striking incidence of bleeding when you shouldn't otherwise have bled so much. You take out a wisdom tooth and you're in the ICU kind of things. So bleeding can be stopped by several different things, and one of them is the vitamin K pathway for clotting factors. And so that's important for almost everybody with Alagille syndrome and almost everybody with any kind of liver disease. And you can give oral vitamin K, like mephitin, or you can give shots if the mephitin doesn't work. And there are a lot of kids, particularly with diversions, where the oral vitamin K just doesn't work. And so you need to go to the next level. The second thing is that in Alagille syndrome, if you have fibrosis or cirrhosis and you have a big spleen, then your platelet count is low. And your platelets are like the plugs after the steel cables sort of get put on these blood vessels. And so that's a second factor. Anyone with chronic kidney disease cannot clot so normally. And then there is this X factor, which the Leakeveris paper showed, which is probably related to the fact that the jagged gene is very involved in blood vessel development. And so there is this theory that there's something about the blood vessels that makes them not normal. And we know that we said last night, and I think later session today, there'll be a lot of time where we'll be talking about, coarctation of the aorta, renal artery stenosis, moya, aneurysms. And so there's something about blood vessels that seems not to be quite standard. So there are so many different issues. And so any one of those that you can effect, and particularly vitamin K and getting the PT to be reasonable, really important. And I feel kids with Alagille syndrome should not be guided into, not too many of them go to play football, because that's like a mass kind of activity. But things like soccer, where the kids head the ball and things like that. Skiing, I don't love. Trampolines, I don't love. And if the spleen is big in our center, every single kid gets a custom-made spleen guard. Because if you pop that spleen, right-handed batter facing the pitcher, skiing with ski poles, bicycle handlebars, something in the car. So we've had, ruptured spleens, and in this kind of scenario, terrible consequences. So that's the other thing I think to guard about, and in head injuries, every baby falls, those sort of things. You have to really get a second look at them and say, are they really okay? And we've sent a lot of kids to the emergency room for a moderate level whack to have them get a CT scan of their head just to make sure they haven't bled. It's more than you wanted, probably.
No, I think that's helpful. So before we move on to the next topic for this session, we heard earlier how G-tubes can be helpful for administering medications. Any other tips or tricks for getting all those various medications into patients? Laura?
I think one thing I just want to add before I pass the mic is that, so a lot of times the hardest part of a G-tube is everyone agreeing, physicians and parents, to do a G-tube. I think the important thing is that they should not be looked as some sort of failure on a parent's part to provide nutrition, that they should be looked as a tool to help your child in this disease. So I think that's the most important thing. I have 2 kids, and as a mom, I know that feeding is the most important part of getting your child to grow. And so a lot of times the discussion that I have is trying to convince the family to look at G-tubes as in a positive light. And kids can do lots of things with G-tubes, as you guys all know. They can swim, they can ride roller coasters, they can play sports. So it's always important to remind yourselves and to new families that G-tubes aren't a punishment. They're something to help your child.
I get the tricks for getting the medicine in. Aw. The G-tube's probably a lot easier than the NG tube. The NG tube people tell you, oh, it'll run all night, and then you're up all night trying to fix the NG tube. I think getting the medicine into your child is going to be an individual process. I think every kid's different. For me, I think I usually advise people take a no-nonsense attitude. It does help. It's not a choice. And it's hard for some parents, I think, to work with their kids with something that's a non-choice. I see a lot of parents say, "Oh, would you like to take your medicine?" You can't ask. It's not a choice thing. Don't give people a choice. I don't care what their age is. If they don't have a choice. You can offer choices for those toddlers, I think, in that, do you want this treat or whatever after? I don't care. Use treats. Use whatever it takes for your kid, and stop feeling guilty about all the ideas about whether treats are a good thing or not. With this, you're trying to get a really important medicine in, and if you have to mix it with chocolate to do it, do it. I mean, you have to set your priorities. And set your priorities and believe in them, and your kid's growing, you're doing the right thing. So we use those kinds of things. You can set up kinds of rewards. I think the basic thing that worked for me was, this is the time, and we do this, and you started it in babyhood anyway, and so I think that pattern is easy to keep, and you just set your boundaries, and it works. I think the only other thing is to remember they will do stuff. My daughter was taking her vitamin K. She decided she wanted to take it on the way driving to school. She was supposedly putting her tablet in her mouth. I'm driving. She's going to be all independent now because she's 5 or so. And I pulled out the car seat, and there were the vitamin tablets. So watch out.
They can get
I think
tricky.
that would be one thought that you brought up was, so kids can actually learn to swallow pills at a really young age. And the liquid formulations are the ones that taste really gross. So we've taught 2-year-olds how to swallow pills, and your child life person, or if you have a psychologist in your clinic, they're really good at teaching pill swallowing at a young age. And if you can get your kids to do that, that's much easier.
Tic Tacs are a good way to start that. Those little tiny candies, because they're not freaking out about that. If they're past their choke hazard age, you can go ahead and have them start swallowing those, and they're not going to fight it as much.
Yeah, in that sequence, mini M&Ms, peanut M&Ms. By the time you get the peanut M&Ms, you can do anything. Yeah, I agree. And I totally agree. I mean, there are weird things, and sometimes taste is so erratic and irrational in this disease that, there are some things that we need to give, like cholestyramine, Questran, that there's really just no way to make it palatable. I agree. Bury it in chocolate syrup, bury it in frozen and then somewhat unfrozen concentrated orange juice. you know, there are tricks that people say that like make no sense whatsoever, and then they work some of the time. So, NG tubes now, 15, 20 years later, pumps are really good. They're really small. They work really well. Most of the kids don't care about NG tubes, but you have to remember, because Alagille patients itch, the tube in the nose is like, the nose is an itch place, ear is an itch place, trunk is an itch place. And so the tube in the nose in Alagille is different than all these other kids where, you know, you'll meet parents with other diseases where one NG tube went in and 4 weeks later it's still in. And that doesn't commonly work so well in Alagille because they just fuss with it. You have that skinny little finger and you have that thing that just sticks out a little bit, and then suddenly they've hooked it, and you know, yeah. So it's a lot of times going to a G tube is absolutely a godsend, and you know, you can do that at 2, 3, 4 months of age, and I would say most parents say we should have just done this a long time ago.
Thank you. And actually, it was a perfect transition to the next topic, which is color and skin. So an Alagille warrior might have a lot of challenges to do with their color and skin, including jaundice, itching we just heard about, xanthomas, prominent veins, or hives. Now, not everybody with Alagille has all of these or has all of them all the time, but I'm sure everybody here is familiar with at least some of the things on that list. So jaundice. Anybody on the panel want to give a quick summary about jaundice?
Yes, jaundice is sometimes comes early on in the life of a kid with Alagille and some other issues with the biliary drain that we talk about. It tends to get better as most of the patient age. They may have periods on and off after that. Jaundice is just a function of the liver. That's another function the liver has. Your red blood cells break down. There's indirect bile that goes through the liver and have to be conjugated and secreted through the bile. Then there's with jaundice, there's a lack in that mechanism of drainage that lead to accumulation of that, what we call the conjugated or the direct bilirubin, and start accumulating because it cannot drain as well. Then early on in life, you know, it can lead us to uncertainty of what the diagnosis is overall in the newborn, and with the combination of that and the stools that do not have color, sometimes biliary atresia it has been something that a conversation that many parents has had in a newborn. But I think also you see it, as I say, most patients are going to get better with time. It can be a sign sometimes that something is changing in someone that has Alagille, that there may be an infection sometimes or advanced liver disease when it returns in a patient that already didn't have that problem.
Thank you. So the next topic, as I'm sure everybody in the room is familiar with, is itching. So by show of hands, has your child experienced itching either now or at some point in their life? So, you know, this is completely not surprising to me. When we started Lumina, the first thing we did was travel around the country to meet with families and understand from their perspective what it is to live with this disease. And itching was the #1 reported symptom. And it was also reported as the most bothersome and highest impact quality of life symptom. And, you know, having spent some time trying to understand this disease from the outside in, I can just relate to how devastating that itch could be. And I think that whether patients have liver or kidney disease, the impacts to quality of life, sleeping, disfiguration, scarring can really be severe. You know, the itching in Alagille syndrome, nobody really definitively knows exactly what causes the itching. It could be caused by buildup of bile acids. I personally believe that has a role to play somewhere, whether it's the actual end molecule that causes the itching or not. There's also endogenous opioids in the system that may have a role to play. Also autotaxin, lipophosphatidilic acid. These are compound or molecules that are naturally in your body that have been somewhat thought to be involved in the role of itching. And whatever the cause is, I know from having spent some time doing research in this space, it really is probably one of the most severe cases of symptoms associated with Alagille, and it's relentless. And there appear to be not yet any magic solutions to relieve it. And people try all sorts of things, different medicines, skins, creams, sleeping on silk sheets, which sounds great, but I'm sure, whether it helps or not. Ice baths, oatmeal baths. I'm sure you've all tried some or all of these things. Keeping nails short, not bathing too often. It's sort of that, too little, too much balance that can really help. But we'll talk about itching in a minute. And I think the one thing that's clear about itching is it's a big, big problem. Somewhat associated in terms of one thing that our research also highlighted was itching around sites of xanthomas can be worse for some patients. Xanthomas are associated with Alagille syndrome. Anybody want to give a thought on xanthomas?
Laura? No. So, xanthomas are lipid collections that we see in the skin that usually more or less start to occur as the cholesterol goes upward to sort of over 500. And as Dr. Kennedy said, there are a lot of things in Alagille syndrome and in medicine where we measure one thing and we say it's kind of like correlated with this, but then that's not really the whole answer at all. But we think xanthomas, we think cholesterol, it's more complicated than that. But so many children start to develop xanthomas when their cholesterol goes up over 500, and most patients with Alagille syndrome start with a relatively normal cholesterol before it's actually measured most of the time. It goes upward, and sometimes it reaches as high as 1,200, 2,000, and then, at my age, if it's 210, they yell at me incessantly. So it gives you an idea, but it's a different risk cholesterol in this group. If you have a few xanthomas, they, particularly in the younger children, they don't bother the child, they're cosmetic, and they're a marker of things. But we have a number of children who literally have thousands of these. And if you get xanthomas in particular areas, areas of trauma, areas of traction, they can really become a problem. So there are people who have them along tendons or on the bottom of their feet, where they're really annoying, sometimes in the ears. It's a place for digging. Had a girl who came in once who sort of had a cholesterol where she, would make xanthomas, but it wasn't so sky high. And all of her xanthomas were right here. And we were trying to figure out, it was really weird that they weren't on the trunk, weren't around the diaper. And then she got really annoyed with us as we were thinking, and her mom pulled out this big pacifier, which this kid sucked into her face like a jackhammer. And we said, you know what? You need to get rid of the pacifier. That's what this is. And it was an area of trauma, just like the hands are areas of trauma, and they're a little bit cooler. So very commonly, you have hands like that, and there are some people where they're little bumps, but there are some people where they are really pea-sized, disfiguring, bumps. There are different strategies for these, and sometimes, there are children who, I have a patient who's going, I think, to the prom this weekend, but who had thousands of xanthomas, and in the care booklet that I think you all got, the little wire-bound care booklet, there's a picture of her at a couple years of age, the backs of her legs, literally just on the backs of her legs, thousands of xanthomas. And then at age 16, nothing. But that's what they are, and they range from cosmetic to horrible.
And what about treatment? What do you do in those cases?
Yeah. So, because they are lipid and probably mostly cholesterol, and it's important to say, in the different things that we think about in our children, the chemicals that we're dealing with come from like normal body things. So jaundice is like bilirubin, but it comes from the breakdown of the red stuff in muscles, myoglobin, and the red stuff in blood cells. So cholesterol is the mother of bile salts. You have cholesterol, and then you do a couple of chemical things to it, and then you turn it into a bile salt, and then you conjugate it with something, and only then can the liver grab it and push it towards the intestines for digestion. So when you can't get the bile salts out of the liver, then all this cholesterol that's upstream from it builds up. So that's the background. I will answer the question. So one strategy for high cholesterol, not for high bile salts, it was developed for high cholesterol, was to take something that binds the bile salts in the gut and pulls them out into the poop. And that's a strategy that has been around for a very long time, before the fancier, sexier medications. And so every time you make a bile salt come out of the body in the stool, the body says, we don't have enough bile salts, and we're going to burn another cholesterol. So that's why that strategy works for cholesterol. Well, obviously it works even better for bile salts, as long as you can make the bile salts go into the bowel. So that's like Questran, cholestyramine, colesevelam, Welchol, those strategies that are decent strategies as long as you're putting stuff out. So a second, and we said the bile salts want to be reabsorbed by the small bowel down at the bottom. So once you're done digesting, and before you get to the colon, the body says, that bile salt is really attractive to me, and it's so hard to make that I'm going to bring it back into the body. And so we actively secrete bile salts in the liver, and that's what drives bile. And then in the end of the small intestine, we actively bring them back because we want to recycle them. And so bile salts are recycled because that's very efficient for the body. So a second thing that has been done is to inhibit the reuptake of those bile salts back into the body. They're good for everyone without Alagille syndrome and a couple of other diseases. But if you have those diseases and you have too many bile salts in your body, you really would like to say, stop, don't bring these back in. So I'm going to let Dr. Kennedy talk about that strategy. The other way to do it so that you can't reabsorb those bile salts is you can either exclude the part of the bowel that has the most of those pumps. So, and we saw a little bit last night, we saw a couple different strategies, but one is to do sort of an internal exclusion. A second is to do an internal bypass to move things from that small bowel into the transverse colon. But the way that most people have this done is a partial external biliary diversion. And I think there'll be a little more talk about that later on in one of the sessions. But where you basically, the bile that gets to the gallbladder, you take some of that bile, you bring it out through a little conduit, a little tube, and you drain it into a bag and you throw it away. So that gets rid of jaundice, and it gets rid of bile salts and a bunch of other things. But the main reason for that is to get rid of bile salts. So another way to deal with this would be to use, and I'm not going to ask all the dads and moms in the audience how many of you are on a statin, but a cholesterol synthesis inhibitor molecule is like, it's like there's definitely 5 people on your block who are taking it if you have a small block. And if you have a big block, like everybody's taking it as adults, and these are the, Lipitor's and so on. And so we have used those at times to, if you inhibit cholesterol synthesis, and most of the cholesterol is synthesized, not eaten in eggs. If you inhibit cholesterol synthesis, then you don't make as many bile salts, you don't have as much cholesterol running around in your blood, and xanthomas can go away. And then the last way is to get past it. So there are many people who grow past that really intense phase of Alagille syndrome and then get better, and that's probably because their liver just excretes better over time. We know that the ratio of bile ducts to portal tracts changes. It changes in the fetus, it changes, it's different at birth. In normal people, it continues to double over the first 2 years of age. It doesn't happen in Alagille syndrome. We know that if you do biopsies on kids in the first weeks of life, the number of ducts per portal tract in many patients is normal. Later on, it becomes abnormal. And then later on, many people, they get better at pumping out the stuff. So that's another way to lose them. It doesn't work at all to like cut them off or scratch them off or anything like that.
Thanks, David. And just to pick up on your comment about the inhibitor, so when we started Lumina in 2012, our drug, our therapeutic approach was to block the transporter for bile acids. And there was some really interesting research that was done by the Alagille Syndrome Alliance. It was a monkey survey from families who had undergone partial external biliary diversion. And there was discussions about itching, there was discussions about quality of life, about all sorts of different things. And there was also discussion about xanthomas in terms of did it help, yes or no? How long did it take? And in looking at that research, what became clear was, if you have a very dramatic response to diversion surgery in terms of itching, that can be quick. That can happen in days or weeks. But the xanthomas piece took longer for the body to really clear out that cholesterol that was resulting in those xanthomas. So when we started clinical trials of our drug that's now being taken forward by Shire, monitoring xanthomas was certainly one of the things that we did. But there are no results yet that I'm aware of that indicate whether this drug is having a significant effect on xanthomas or not.
So David, can xanthomas be thought of as kind of protective in the sense that if two patients have the same level of cholesterol in the serum, the one that has xanthomas has less cholesterol circulating and causing other problems?
You could think of it that way, but I think of it, I'm afraid if I'm going to say this I think we're on camera. I think of them, the xanthomas are a little bit like the cellar of my house now that my kids have all moved out. And they deposit things that crystallize in my basement, whether I approve it or know it or not. And then the other stuff just keeps coming. So I think there is a protective effect in lipids in Alagille syndrome that makes them very different from patients who have like familial hypercholesterolemia at the same age. But this is a bad luck deposition of lipids and probably complex lipids that doesn't probably have, yes, it makes the cholesterol level perhaps slightly lower because they go somewhere, but it doesn't help patients in any way. And you know, if you count the total amount of this waxy debris that some patients, just even in their hands, you sometimes have the feeling that like 20% of the mass of their hands is in these xanthomas. And I think part of it is, you know, lipids, they don't seem to deposit the way they do in other diseases in the same way. And if you think about it, and you were talking about all the different fats and first press and second press and you know, lard and Crisco and all these other things, fats are an expensive chocolate are liquids or solids right around room temperature, body temperature. And so, you know, many of the fats that we have, when you drop the temperature even a teeny bit, they go solid. And so part of this, if you think about it, some xanthomas are really a skin thing, but they're also a skin thing of cooler extremities. And I think it's a precipitation of fats in areas that are favorable for pulling the cholesterol out of the blood, and then they don't want to solubilize and go back in. And as Dr. Kennedy said, even if you know your cholesterol is dropping and you're doing great, it sometimes takes a tremendous amount of time, measured in years, for these things to go away.
So let's talk about itching. In terms of itching, what you do to treat it, what's new on the scene for itching, what's maybe hopefully causing some hope, but you know, where is medical understanding of how to you know, of the mechanisms of itching and the treatment of itching? Where are we going?
So I'm going to punt the brand new back to Dr. Kennedy, and then, given my age, I will do the old.
Okay. Do you want to start with the old and then we'll go to the new? Start with it.
I'd set the bigger picture is you can either treat the compounds that you believe cause the itching, or you can treat the process of itching, or you can treat the reaction to itching. So so the strategies are in very different buckets, and no one who has big itching responds to one agent. So you kind of need one from A and one from B and one from C. So what is new is the science of the understanding of itch fibers, itch compounds, and then one of the strategies is very new, so that's two things. And then I think the third thing, which is good and bad, is that everything that we used before the very recent modern era never really had to be studied, was never studied in kids, was never studied in kids with Alagille syndrome. And every doctor who treats kids with Alagille syndrome uses every one of these. And now the new standard going forward is you have to prove that it works. You have to prove that it's safe, which is easier. Prove that it works. Prove that it works in studies that are now defined by, like, the FDA, and rising to the same standard as many other medicines. And so there really is kind of a branch point between what we've always used and what we hope to be using as strategies going forward. But itching it's not just Alagille syndrome. There are so many other liver diseases where itch is, you know, a visceral, omnipresent, you know, really, you know, terrible symptom. And so there is a broader market, but Alagille syndrome has sort of highest cholesterol, highest bile salt levels of almost any disease ever imagined. So I'll set the stage with that, and then we'll go to the new.
Okay. And I know there are sessions over the rest of the conference that talk about research and conducting research and drug development specifically. So I'm not going to get into nitty-gritty details of what is involved in adhering to the standards that David just mentioned. But suffice it to say that, you know, I think Cindy, is Cindy still here? No. So I think at the last conference, the last Alagille conference, there was one company present, and that was Lumina, actually Lumina/Shire, who had just been acquired by Shire. Prior to that, I don't believe there have been any drug development companies. Wanda's shaking her head here. This year, there are 3 companies who are interested in developing new treatments for Alagille syndrome. So I think that in and of itself is something worth noting and actually something worth celebrating, because that means that there's more thinking from a drug development perspective about how you tackle and how do you study this disease. So the evolution of Alagille syndrome in terms of clinical development has been rapid and is very new. So I think that's all really good news. And I know that there are folks here from Shire, and there are folks here from Albareo and a company called Sidan. And I can only speak to the Lumina Shire experience, and I'm no longer associated with the company. But what we did was initiate a number of clinical trials across the world to look at Alagille syndrome in what's called a controlled manner. So some of the patients are on the drug, excuse me, and some patients are on placebo. And you have to do that so that in order to see a difference. Now, the challenge with conducting a trial like this in Alagille syndrome is there's not a lot of patients. You know, if you're going to go out and study a statin, you're going to have trials with 5,000, 10,000 patients. We were conducting studies with 20 patients or 30 patients. So individual patient responses can make a really big difference in how you interpret that data. So the data from the first study, and I believe the only data that's been presented publicly for Alagille syndrome, was presented at a large liver meeting in Europe in 2015. And what it showed was there were some patients who looked like they were having a really good response, and there was a correlation. So when their bile acids went down, their itching went down. And that was 18 patients worth of data, and I know that that data has been evaluated upside down, inside out, backwards, forwards, and you can look, you know, the company is looking to see how to move that drug forward. I know there are people here whose children are in the Shire studies that are being conducted with the Children's Network. But I would say two things. One, it's fairly early days in terms of clinical development in Alagille syndrome, but it's great that it's happening. And with the Shire product, it's a drug that blocks the transport of bile acids back to the liver. So theoretically, all that bile that is being released is being pushed out in the poop. and that potentially could have a benefit in terms of itching. It could have a benefit in terms of xanthomas. You know, there's also a theoretical benefit in terms of fat-soluble vitamins and vitamin levels, because the bile that's there in the GI tract is there for a little bit longer. But I think that there's a lot more work to be done and data to be analyzed to know whether there's really truly an objective difference, and whether that's a package of data that the FDA would approve so that this drug becomes available outside of the clinical trial setting. But it's very exciting times, and I encourage you to engage with and talk to the folks that are here from Shire and the other companies to understand how they're thinking about conducting research and doing studies in this space.
Yeah, I just want to mention that we have come a long way. From the time that I trained about 20 years ago, bad pruritus or itching, bad itching was the reason to transplant a patient, actually. And obviously, we'll talk about transplant in another session and the pros and cons, and it really trading one disease in a way for another issue. But seeing what has happened over the past 20 years has been really outstanding, because I think we are preventing a lot of liver transplantations. Not a lot, but a large proportion of these patients will, because if you deal with a kid with Alagille, I mean, this is one of the main struggles that you have as a parent, is how this kid is. And for us, sometimes before, now we have more tools, but before it was just very frustrating because we could not release or get the kid to a point that he will feel better. But now we have a little bit of better understanding. I just want to give that perspective of what has happened over the past 20 years. I mean, we are in a much, much better place.
Okay, so we have about 2 minutes left before we break, and I just wanted to touch base on prominent veins, especially around the eyes. Is this normal? Is there a relationship to Alagille syndrome? Is there anything that can be done about them?
So it is I didn't realize this was, or maybe I should have realized. It is true. It is striking, very impressive, only in some children. Um, and it seems not to be correlated, as best we can tell, with, when veins are dilated, they are either there's too much flow going in, too little flow going out, or you've been standing too long and they just get stretched out. I mean, that's and so veins get dilated, like the portal vein gets dilated. It's a different mechanism. There are veins that get dilated on the abdomen called the caput or caput medusae. There are sometimes connections between arteries and veins that are abnormal. So we see this, and I don't know who sort of brought this up, but sometimes it is very striking, and it's sort of bitemporal. And when we've looked, we haven't really found a cause, but it is Alagille for some reason. And we haven't correlated having this as a 3-year-old with something else happening 10 years later. So, but if whoever has noticed that, yes, there are certainly others, and I think in my office practice, I don't usually take pictures of faces, but I take pictures of veins because I keep sending them to the neurologists and saying, what's the flow issue here that causes this? Part of it also, I think, is a little bit thinner, translucent skin, and we talked about skin being darker or jaundiced, but there are a number of patients with Alagille syndrome and liver disease where hair pigmentation and skin pigmentation is much less than what you would expect typically for the family's complexion. So I think that also emphasizes it in some of the patients.
Any questions about itching, jaundice, skin, poop, or anything else that we've discussed this morning? Or
When you were talking about their skin color and it being lighter, is that something that is related to the liver directly, or just Alagilles in general?
Yeah, so that's a great question, and the bottom line is it's probably different in different people, and also we don't seem to know. So there are some people who they have a hair color and a skin color that seems like it's just missing yellow or brown kind of pigment. It's not really blonde. It's kind of like, and for a very long time when we did TPN, intravenous nutrition, back in the 70s and 80s, all of the kids on not all, but many of the kids on TPN looked like this. And we felt that it was some micronutrient deficiency or imbalance. And many people with Alagille syndrome have very high coppers. Some of the highest copper levels in the liver ever seen have been in Alagille syndrome, because one of the things that the liver excretes that is critical to excrete out of the body is copper. We said that copper and zinc balance. Well, copper and zinc are both involved in collagen and skin and some of these other things. And so it is probably a downstream metabolic consequence of some of the abnormalities in Alagille syndrome. But we've looked at selenium, magnesium, manganese, biotin. We've aimed after those things, which were some of the answers in TPN. And we haven't really found some overriding deficit where we could say, I can get more color into your hair by giving you vitamin X. Break time.
I would like to thank the panel and thank everybody for being so engaged. We will be back at 10:45. Thank you.